Thank you so much for the introduction. So in today's session, I'm going to be talking to you about social protection and mental health. Okay, so social protection. There are many definitions of social protection. Essentially, it is concerned with preventing, managing, and overcoming situations that adversely affect people. These can include poverty, unemployment, disability, age, gender, and many other social differences, something that we can see in all parts of the world, not just in poorer societies. The social protection is policies and programs that is aimed at helping vulnerable groups and people to overcome situations and become more resilient against crisis such as poverty, by ensuring food safety, healthcare, housing, education, training, employment are provided. There are many research in social protection linking with mental health, well-being and mental health problems. Research in this area has often shown that those who score most high in distress are the ones who have the most demands on themselves and the least resources to cope, such as women, people who are unemployed, people with disabilities, people with low socioeconomic status. BAME communities are often seen as a group of people that is disadvantaged in most societies. They are more likely to experience poverty, have poorer health outcomes, have poorer educational outcomes, tend to have higher unemployment, more likely to be in contact with the law, and may face a lot of challenging accessing services that are culturally appropriate and linguistically appropriate too. Another inequality, and one that we need to think a bit more about, is also women and mental health. So there are many differences in, statistically speaking, there are many differences between men and women and how they experience mental health and how it's played out in terms of statistics. There was a survey, national survey done in England in 2014, where they found that 1 in 6 adults of the adult population had experienced common mental health problems. 1 in 5 were women, whereas 1 in 8 were men. Statistically speaking, and widely, almost 1 in 3 women at adult aged 16 to 59 will experience domestic violence in her lifetime. Women experiencing domestic violence are also more likely to experience mental health problems, and women who experience mental health problems are more likely to have experienced domestic violence. There is enough data and research to support this. Many feminist studies and feminists, psychologists, critical psychologists have also documented on the findings that women tend to be far more vulnerable to depression due to the social conditions that their lives, everyday lives, are embedded in. So mental health and women living with HIV. So in our clinic at the Royal Free Hospital in Charleston Day Centre, we have over 3,000 patients in our clinic. Majority is men, 2,288, and 850 are female. Age range is between 40 to 59, and the mean age range. Of the 852 females, majority, and that's 658, are Black, British, African, Caribbean women. Usually what the referral is for, in terms of clinical psychology, referrals to us is for depression, anxiety, adherence problems, family and disclosure. However, in this same population group of the majority Black, British and African women, the adverse and external problems that we see that really do take over a lot of their clinical presentation are poverty, unemployment, most of them have been in war trauma, racism, a lack of power, domestic violence, childcare, immigration, isolation, a lack of activity, leisure, all resulting in higher mental health issues, stress, reduced quality of life, and potential physical health problems too. So taking some of this into account and my own experience of working in this clinic with Black females, I am quite confident in saying that psychological problems emerge from adverse conditions and are often maintained by the person's lack of powers and resources to change the situation. Generally, and that's not just women with HIV, generally people living with HIV, men and women, are more likely to experience higher rates of mental health problems than the general population. They're more likely to experience depression, anxiety, and adjustment problems than any other mental health problem. There are also potential difficulties that they will experience at various transition points in their HIV career, so to speak. First of all, from the HIV diagnosis, often what we see in our clinics and from our patient group is grief reaction, adjustment problems. Being HIV positive, having identity issues, as well as managing sexual activity, comorbid problems, pre-existing mental health and physical health problems, disclosure, so in relationships and in families. Medication is another area where we do see a source of problem too, where there is difficulty with starting, changing, adhering and managing side effects. Major life decisions, so everything that is quite a complex area of decision making and managing that we all experience. People living with HIV experience much more difficulties around these situations, such as work, marriage, pregnancy, housing, benefits, immigration, criminalization, all sort of complicated by the HIV illness. There are also long-term conditions, pain, fatigue, illness, hospitalization, HIV-related cognitive neuro problems, and palliative problems. So a variety of issues that a person diagnosed and living with HIV will experience from their diagnosis to aging. So what are the psychological work that we do in our clinic with patients living with HIV? So often we know that if the mental health issues are not managed, it makes it very difficult for patients to adhere to the ARTs, attend appointments. They also tend to have poorer health outcomes, frequent hospital admissions, and increased mortality. Enough data and research out there to state the same thing. Psychological interventions can make a huge difference to the person's health and well-being. The interventions that we provide in our clinic is aimed at accepting and adapting to living with HIV, education and management of other mental health problems such as depression, anxiety and substance misuse. Another piece of work that we do is also involves removing HIV stigma. It's a very challenging piece of work because stigma is real and it's often experienced by a lot of people living with HIV. So it's something that we routinely see in our clinic, often reported by patients as shame, self-blame, poor self-esteem, and fears of being rejected and discriminated. The work, psychological work that we do with patients experiencing stigma is first increasing the knowledge and understanding of HIV, which helps to reduce stigma, and rather than seen as a death sentence, people can see it as more of a manageable condition. Increasing adjustment and acceptance, rather than avoiding having this diagnosis or trying to get it out of them, finding a way to live and adjust to having this condition. Improving self-esteem, so rather than HIV spoiling their identity and who they are, it's also about improving the self-esteem. You know? And finally, connecting people living with HIV with other charity organizations so that they don't feel isolation and lonely. So, do psychologists deal with social inequalities and the issues that we've talked about at the beginning on social protection? I'm going to be very honest and say that most psychological theories don't. You know, they don't show an adequate awareness of inequalities. Neither do they do very much to address them. However, my qualifications, my own personal history and background, and where I've studied, all has swayed me to go towards critical and community psychology, an approach that is interested in applying psychology to understanding these social issues and attempting to do something about it. You know, in practice, what that looks like is first of all, in formulation and assessment, understanding patients' issues are within their social context, and making sense of how wider societal arrangements and structures such as economy, culture, social, political and so environmental factors affect someone's well-being and health. So we're not simply just looking at the mind and how people have dysfunction in the brain and their thinking, but we're trying to understand the social context behind psychological issues. Secondly, offering therapy that goes beyond the therapy room. We must look outside. In order to support somebody, we have to look outside the therapy room and think about the impact that the social context is having on them, and possibly intervene at that level. And thirdly, it's really important as psychologists that we have the knowledge, about psychological well-being and theories that explicitly makes you see how social context does affect our psychological well-being. So it's about disseminating some of this knowledge to educating other health professionals, public and policymakers about these wide range of social issues. These can include programs such as domestic violence prevention programs, HIV and AIDS prevention program, a variety of things that we could do to use our psychological knowledge to make a difference. So other helpful approaches, and one that is extremely close to my heart, is narrative therapy. This approach is a non-pathologizing approach that enables us to look at the problem as the problem, not the person. It's an empowering approach that is collaborative, and it's about highlighting what the problem is, how is it located in context, deconstructing the context and talking about it, making them more visible, and thinking about the impact of the problem that is having on the person, and focusing on the person's unique outcomes. So these are the times when the person has resisted the problems. Narrative therapy is about stories, and it's about developing and bringing to surface subjugated stories, so stories that are weaker but are there, about strength, resistance and resilience. It's about focusing, reauthoring some of these stories as opposed to the dominant stories of, say, trauma or abuse. The truth is our lives are multi-layered, and there are multiple stories that we can tell people about what we are, what we have experienced, and narrative therapy is about rejuggling some of this so we can talk about stories of strength and courage rather than just trauma. Systemic family therapy is another therapy that focuses and is interested in context, systems, a family, social relationships, and the idea of multiple truth and experiences. Is interested in using these ideas to formulate problems and finding solutions in systems and the person rather than fault. And finally, solution-focused therapy. This is quite a brief therapy that looks for solutions to problems. It's not really focused around talking too much about the situation, the past and what has happened, but it's about trying to overcome the obstacle by focusing on some goals. You may have come across this very old theory and an approach referring to Maslow's hierarchy of needs. This is also quite close to critical psychology and also highlights the importance of having basic needs such as safety, security, food, water, warmth, rest. Those needs, the material needs and the basic needs first, in order for us to move on to the next stages and accomplish other needs. So self-esteem, prestige, feeling of accomplishment, self-actualization, needs that cannot be met unless we actually have the basic needs met first. It's a really interesting approach, and I've heard of it many, many years ago in my training, and still strikes a chord with what I feel about what we should be doing as psychologists. So in therapy, what will be what I urge other psychologists, other professionals who are working with patients in a therapeutic way, is to address some of the social inequalities within our sessions. So first of all, in the assessment and formulation, it's really important that we look at the individual's world and recognize the impact that the social environment is having, rather than attributing the problems, mental health problems, in minds and brain. That's a very important key. We cannot just simply think people's problems are occurring because they have a dysfunction in their brain. We have to look at what's going on in their lives. So we have to look at the history, the social context, and the impact of these on the individuals, such as family, social, education, and work. We have to look at the current difficulties and what the unfulfilled goals are. You know, what are the barriers to progress? We have to look at the strengths and resources, coping strategies, and material resources, one that is extremely important, one that I will go into a bit later. The therapy work has to be collaborative. The interventions has to be patient-led. It's not about the therapist is an expert, but it's also the patient is also an expert. It's not about what we know, it's also about the person knows. So they need to be leading some of the intervention. We have to, in the therapy, we have to go beyond the therapy room. We need to help these patients access power and resources, such as employment, benefits, community networks, secure housing. At the end of therapy, what will be really important for us to do is seek whether the therapeutic intervention was helpful by asking for direct feedback. Indirect work would mean offering more education, consultation, and support to communities at large, not just to this individual. So if you could do some couples work, if you could bring other people in the room, so be it, and do it. So addressing social inequalities in therapy. So in therapy, it's really important to support someone to make a bit more sense of the situation and enable them to have more control over their life and help them to the things that they want to get in life. And again, like I said, it's not about transforming the thinking and attitudes. Changing, finding jobs, moving houses, forming new associations, acquiring knowledge, abilities. These are everything that we must be doing in order to make a difference to people. And what we need to do as therapists is identify and help the person to gain powers and resources that they need to tackle these problems. So this is a theory and a tool that we could be using in therapy that focuses on some proximal factors such as home, family, social life, material resources, personal resources. We could literally put this in front of patients, ask them where are they in those kind of irrespective areas. These are the areas that we can make a difference in with a little bit of effort. An important area is the material resources. We need to be asking whether the person is fulfilled and satisfied with what their education, work, money, and health and physical environment. So using this tool, it would be good to help the clients to map out the current circumstances, their powers and resources that's available to them, pay attention to the material resources that lie at the root of the difficulties, and help clients to make a difference in those areas. So work, education, relationships, family, try to make a difference in those areas because that will make a profound difference on the person. You know, money, employment, education, very, very important things. Examples in HIV settings that some of the material resources and some of the things that we do to help patients get some material resources include the following. So acknowledge the importance of housing, income, social context and well-being. Goals at the end of assessment means asking patients what they need help with, problem solving about money, immigration, unemployment, and parenting, referral for benefit advice, referral to employment services, referral to food banks, referral for advocacy and legal services, referral to safeguarding and domestic violence services, writing support letters for housing and immigration, hospital transport service and travel expense forms, and then building alliances, so meaning referring them to other charity organizations to reduce isolation and loneliness. Examples of personal resources and how to gain them. It's really important as therapists that we offer therapy for mental health problems. We offer therapy that develops on strengths rather than focusing on diagnosis. We make therapy accessible. We focus our sessions on being assertive, resilient, confidence building, independence, and recognizing things like domestic violence. Adapting therapy so it's culturally sensitive. We offer virtual appointments. We also have a patient forum where we ask patients how they view the service and what they want from it. Annual survey seeking views of patients about what we've offered to them in the last 12 months and peer support. Other ways to increase personal resources is to think about building resilience. So resilience is the ability for us to adapt over time to trauma and challenging situations. And the 4 areas that as psychologists we focus on building resilience is connections, wellness, finding a purpose, and embracing healthy thoughts. Other ways to increase personal resources is acknowledging how you're feeling and expressing your emotions, accepting what is happening and focus on things you can control, being present, keeping a journal, self-compassion, staying connected to friends and family, exercise and meditation and mindfulness, engaging in activities, reducing drugs and alcohol and tobacco, and focusing on solutions. Thank you for listening.